Good afternoon. May we start? Can start, right? Good afternoon, everyone. I hope you all had a good lunch. Welcome to workshop session 3 on optimizing campaign data reuse. As we engage in discussions and have our conversations, I'd like for us to all bear in mind or think about key elements when we talk about data reuse. So things such as data harmonization, efficiency gains, improved targeting, interoperability between systems, collaboration, and governance. So in our discussions, these are, I guess, some key elements that we should bear in mind when we think about data reuse. And with the aim at the end of the session to sort of incorporate this into our local context as a means of establishing. Okay, so I was saying, so we should think about this in terms of our local context as a means of us thinking about possible requirements that we need to establish a framework for leveraging malaria ITN distribution data across health campaigns and multi-purpose health initiatives. So I think that's the aim of the session. By the end, we should have initial thoughts on a possible framework that we can apply in our context. So I'm going to quickly just request all the facilitators and presenters to present themselves, then we can proceed to the next slide. Thank you. So over to you.
Okay, hi everyone, good afternoon. I'm Elijah Egu with CRS as the Senior TA for Digital Health, Technical Advisor for Digital Health. Thank you.
Good afternoon, everyone. My name is Hervé Muneza. I am from IGAF. I've been supporting the digitalization in a couple of countries.
I'm Justus Boachiadom, IT Manager, NMEP Ghana.
So, unfortunately, we don't have Dr. Rock in the room. I think he has an emergency that he needed to respond to the Ministry of Health, and he's going to be here shortly. So in case we get to his part and we skip, so please don't mind us until he gets here. Thank you.
All right, so this is our workshop outline. We're going to first start by doing a quick survey. So the barcode will be up on the screen, and I'll request the participants to scan and quickly fill out a survey on Mentimeter. So that's going to be our icebreaker. And then we're going to have a series of 3 presentations, one on campaign data structure and opportunity for reuse, 2 presentations on real-world examples of ITN distribution data reuse with the case of Ghana and Benin. After that, we'll have a breakout work session to discuss what data should be standardized across campaigns. We'll then have 2 presentation and QA sessions, the first on data quality and opportunities for data reuse through establishing data registries, and the second on data processing before reuse, identifying key partners, collaboration strategies, and framework for reuse. And lastly, we will end with a group activity where we'll start to now think about this framework or a roadmap that could be developed for data reuse, and as I mentioned earlier, applying it to our local context. So initial thoughts on the design of a framework for data reuse. So I think we're now going to get the barcode up for us to scan to access the survey. I'll come around just to support with that if needed. Thank you. So just grab your phones and please scan the QR code. You should have access to a survey. Have we already started filling out the survey? Do we all have access? Yeah.
Um, it appears that some people have started utilizing the Menti, so please let me just clear it. All right, because I think we want this to be a bit quite interactive, so let's just give me a minute. Let's see. Let's see here. I'm coming. Yes. Okay. Let's see.
Clear results down here.
All right. So let's go back to it. 1 minute. If you need help scanning, we can. Let's be sure that everyone has scanned. Has everyone scanned? Okay, so I think we can start. 4 people have yet filled it, so it's okay. I think we can still just continue this way. All right. So I think the first question is, do you agree that health campaign data should be reused for other campaigns? 6 people said yes already. I think we are about 22 in the room, so let's get more responses. Could we get more responses? 8. Okay. I'm looking out for one person who will say no. So we can maybe just find out why. Okay, 10. 10 responses. So let's keep moving. We've had 4 more responses have been filled, but it's okay. Why do you agree? I see 2 key information here. First, the processes are similar from a campaign to another, collecting field data and precise geographic coordinates to plan accordingly. It helps save resource to reuse this data, which I think it makes a lot of sense. I think the 4 responses on this side are saying the same thing. We have one person here as well saying for integration. I think I would just want to kind of highlight that because we would actually be speaking to it shortly. Somebody here is saying to reduce total cost of health activities. I would also like to see data shared outside health to reduce costs to governments at higher levels. We would also be discussing that. Okay, so let's, since we did not have anyone that disagreed, some people disagreed. La ressource entre utilisée pour d'autres activités de la campagne. Okay. I think the person is saying that the resources could be utilized for other activities in a campaign. I think he agrees. He doesn't disagree. All right, so let's keep going. We are so sorry we don't have the French translation of this, you know. So let's see, could health campaign data be used as baseline for routine health intervention? 7 people have said yes, 1 has said no, and 1 is unsure. Okay, 8 people now are saying yes. Could we get up to 15 responses so we can, let's see. Oh, 9, let's see. 10, okay. Could we know who said no? The person that said no, I would want to just hear from you if it's possible. Oh, great. Terry, let's know why you said no.
The only reason I said no is because during, and I'm assuming this is during campaigns, there's a lot of resources available, but when you're doing like other activities, you don't have the same resources available. So using data in a setting where there's a lot of resources can be quite deceiving, as opposed to when you're working when you have limited resources. So that was the only reason why.
Thank you. I think that's a good point, and is one element that is also covered in the framework that we'll be discussing. Two people are unsure. Can we just get an indication of who was unsure? So we can hear from you. Please don't be shy. Okay, let's keep going. Also, this has, okay, 10 people have filled this already. As a program manager within the SMC unit of the Ministry of Health, would you be willing to utilize the enumeration data from an ITN campaign? 11 said yes. One said no, one said unsure. Can we have who said unsure, please? Anybody? The person that said unsure? Okay, let's keep moving. Okay, let's see. We have the next question and a lot of responses already. If willing to reuse ITN campaign data for SMC, why? So let's see the reasons that they have given. Yes, covers all households, lack of funding, same intervention area, it saves time, it would reduce time and costs for my SMC campaign. I like that this person has personalized it, right? That is going to reduce costs for my SMC campaign. It should contain all the needed household information I need for SMC. That's a great feedback. Let's see. ITN data has under 5 population. Excellent. That's also a good point. But I think I have an argument to that, because in some campaigns we just receive like the count of people living in the household. So this means that we don't know the exact number of those that are under 5. But I think we are going to take time to go through this. So let's keep going. If unwilling to use ITN campaign data, let's see what we have received as responses. It is usually exaggerated. I think this is a key concern, and I think this framework that we would be discussing would help us to know how to address this concern, you know, ensuring that we are kind of comfortable to reuse this data we get from an ITN campaign. Yes, may not have info of children under 5. Major shifts have taken place, e.g. migration, inaccurate data from the last campaign. Exactly. I love these responses because these responses is helping us to set the tone of how we want to actually be looking at this framework. All right, let's look at the last question. As an ITN campaign manager, what step would you ensure to give your enumeration data good justification to be used by other programs? I think we are going to stay on this slide a bit so we can see what we think around this. So first is prove that this data is complete and of high quality. Okay? Ensure that household registration data is complete. Okay? Data collection and HHR data validation. Okay? I would consult the managers of other programs in the planning for the enumeration of the item. This is an excellent point. This is also part of the framework. Excellent. I would want to hear from the person that gave this comment. Prove that the data is complete and of high quality. Can we know the person? Excellent. So how do we prove? Can we get the second mic, please? How do you think we can prove this?
Well,
My best guess would be to have the satellite layers, have visualizations with the enumeration data, and I don't know, somehow check that it matches satellite visualizations. That's just one idea, but.
Excellent. And in a case where you don't have GIS resources at the Ministry of Health, how else can you prove?
Triangulation with other sources?
Triangulation, excellent. Thank you. All right. Looks like we have made a lot of progress with this. So the next question is, within your Ministry of Health, who is better placed to manage the baseline data that should be used or reused by all programs within the Ministry of Health? We have a response here, HMIS unit, the Planning and Data Management Department team. I think this is kind of contextualized to the different country context. But I think the key point here is we are kind of recognizing, I see something interesting. Directorate of Policy Planning and Information. Directorate of Policy Planning. Please, who came up with that? Excellent. Please, could you just explain how this works in your country?
Thank you very much. So this is the directorate that is responsible for all health planning and then hosts the Health Management Information System, the DHIS2. And they work very closely with the Statistics Sierra Leone and then the National Civil Registration. So they are all working together in terms of population data and all the rest. So all health programs are like working through all MI units of the Ministry of Health. They get their directives from the Director of Planning and Information. And then they also had the surveys that are being conducted by the Ministry of Health.
Thank you so much. I think with these responses, it is kind of showing us that we have a sense of how the framework should work, right? Because it's very clear who should be responsible to, manage the data across the different ministries of health. So I think this is going to make the discussion very, very easy in the context of establishing this framework. So I think this is the end of the Menti. We will go right to the next presentation. Thank you so much. Okay. All right. Okay. So before I start, could you help me look at your neighbor and ask them of their names and tell them you made the right choice being here? Tell them you made the right choice being here. Okay. Excellent. So, I am very, very excited about the topic, and this is because, it's a work that we had begun at CRS since 2020 in the Republic of Benin, and we have been hoping to gain a lot of traction with that, and we have faced a lot of confrontations. And the confrontations that we have faced, it has kind of ranged from key issues of policies, of people, of approaches, and the processes. It was less of the technology. So in view of this, we obviously on our digital health team, we kind of thought through it and we're like, okay, let's see how we can kind of push out the message more to key stakeholders like yourself, to see how you guys could help us understand and also help us in the context of helping us to reshape the framework up until when we are ready to kind of roll out that framework and expose it to other ministries of health who should be using this. So before we headed out to in the context of understanding, okay, should we be reusing campaign data? Yes or no? I think the first thing was that we kind of, we took a step back and we're like, okay, let's look at the research institution, right? They generate a lot of data, and they reuse a lot of data. So this means that obviously they would have a lot of lessons that they would have learned through years, through time, and so on. And please also note that the kind of data that is being used, you know, in the science world is more complicated than what we generate in the context of health campaigns. But of everything we read through, I think there was one article that stood out. And it is this publication by Harvard, you know, data science team. And the publication was this. In summary, all right, data reuse in the sciences is a complex process that depends on what? Trust, expertise, policies, knowledge, infrastructures. Now, please take note of this. It's not saying that, you know, it was depending on technology infrastructure. It said what? Knowledge infrastructure. So if you help me to look through this, right, you will notice that the key point here is people and process. It's less of the technology. So what this means is, if we must reuse data, we must build a lot of trust in that data. People must be able to trust and have a lot of confidence in the data. 2, expertise on the use of the data would have to actually be cultivated deliberately. 3, you must have good policies, you know, standard operating, you know, SOPs and so on, to help to guide the use of the data, the generation of the data, you know, influencing the incremental use of the data as well. So all of the details of this paper, it can be found in the link. So please, if you have you have the slides, please, you can just read through it quickly. So now, let's bring this back to our context of health campaigns. So first, in public health terms, when we say data reuse, what do we really mean, right? Because some people, you know, in the context of how we are trying to look at things, on the clinical side, they see this data reuse a bit differently. The laboratory team as well, they see it a bit differently. But we on the campaigns and the routine side, I think we have a common sense of what we mean in our context of reusing this data. And in view of this, I think we kind of just agreed on a common term that we would just like to establish here. And please let us know if you think otherwise, and of course we can update this as needed. So here we said that, you know, in our context, it kind of signifies using previously collected data or generated information for purposes beyond its original intent, such as health campaigns and routine health interventions. So in the context of the conversation that we'll be having here, we would want to kind of just limit it to this perspective. Now, what kind of data do we get with health campaigns? So we get partial demographic information. So what this means is that, you know, like we get like the name of the head of household, the number of people living in the household, we get the geo coordinates, but we still have some other aspects of data that we don't receive in the course of a campaign. However, in the course of the campaign, all the data we received can be reused in different contexts. And I like that point that was made, you know, outside of health, outside of campaigns, in things like livelihoods, you know, and so on. Can they reuse our campaign data? If yes, how? In as much as we don't receive all this demographic information. So all of this would actually be addressed in the context of our framework. Now, we also have this point, which is interesting. Financial data and learning resource are mostly reused than the population data we receive in health campaigns. Okay. Yeah, we are back. Okay, is this true? Do we agree that financial data is mostly reused? There's a study around that. I think I'm going to cite it in the final slides. So, you know, if I want to ask like campaign managers, in the last campaign, health community workers were paid, let's say, $5 per day. If you want to do a new campaign, the first thing that, you know, the LFA will even ask you, or if your program team will ask you is, please, can we have the budget of the last campaign, right? And we just update it. But we don't do the same in the enumeration data. So why do we now trust the financial data more than we trust the operational data? Why? Who knows the reason why? Who can explain why? Why do we trust the financial? Yes, please.
Well, financial data is funded, it's numbers. We have prices. The source of information is, well, more reliable than that. And then sometimes the financial reports shows that the deviation was not so we can trust that data. When it comes to campaign, normally the reports, they will come showing challenges, and one of the challenges is saying population data, household registration data, macro planning, whatever. So, you know, that's why we are not relying 100% on the previous data. That's my opinion.
Thank you so much. I think I agree with you 100%. In summary, I think just because we have some level of proof and reference, it's easy to trust that data. Now, I have a question. If we take our population data at the end of a campaign and we are able to establish things like proofs, you know, identify like the errors and clean it and have a justification for why the population is like this, do you think that we would be able to, you know, easily build the trust in that data going forward? Do you think that's a reality, Mr. Zandam? Absolutely. Absolutely. So I think these are the things that we are going to use this time to uncover in the context of this framework. Now, over the course of all the campaigns that we have been privileged to implement at CRS and those that we have also seen, we have noticed that we have just two types of data structure across all campaigns. It's either you are receiving the data at the household level, or you are receiving the data at an individual level. With this, I may just want to pause and ask, do we have any other structure that has been identified apart from household and individual level in this room? Anybody has any other contrary experience? Good. So I'm going to go with this assumption. This assumption is correct. So let's keep going. Still on I-10 campaigns, right? Now, I-10 campaigns provide a unique opportunity compared to other campaigns. I think this is the reason why we are advocating to use I-10 campaigns to establish the registries, the beneficiary registries and so on, as against other campaigns like SMC and all. But I think the key question that you have on your mind right now is, but we have a lot of issues of inflated households and missed communities. How would we use that as a baseline? I think those are the things that the framework would also be helping us to address. Now, what are the possible, challenges for why we can't use the ITN data as a baseline? So first, possible chances of not enumerating the urban population. If you agree with me, in a lot of our campaigns, like, in the area where some of our big bosses live, even to access these communities and even just distribute the nets, you know, at the gate they're like, no, we don't even need these nets. So this means that we will not have those records. And I think this is almost the case across our campaigns. 2, we have the issues of inflated household sizes and all. And then 3, we still have things like, you know, population data entry errors, in as much as we have like validation rules within our application and so on, but we still have these errors. And false population entry to acquire more nets. And this is mostly on the side of the community health workers, you know, like they have the devices and they also have the vouchers. All right, so, you know, they can decide to add as many households and keep the vouchers and use them to, you know, to access this net. Now, let's look at a typical ITN campaign data set. And let's just understand the kind of data we collect. So, as you can see, in most cases, we are able to establish the administrative unit. Then we have like the name of the head of household, you know, and then we have the phone numbers. And in most cases, we have the number of people living in the household. I think in that context is the people that sleep regularly in the household. Then we have like the geo coordinates, which is a digital campaign. And we also have the unique identification of the household as well, if it is a unique, if it's a digital campaign. So in some contexts, we use like the voucher as well to link with the household ID as a mechanism of accountability and all. Now, let's look at this data set in the context of other campaigns. Okay, just before that, maybe I will actually just call out one of the countries. So now, in most countries, we receive this information for ITN campaigns. Now, let me just show you a major shift to this trend in one of the countries I will actually be presenting in a few minutes. So, this was the data set that was collected in the 2020 ITN campaign in Benin. So, as you can see, we have a total of 12 primary data points. Secondary data points now had 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. 10 data points per individual in the household. So this means that we had a total of about 25 data parameters that was received for each member in the household. And the question is, oh, how did you guys, you know, pull this through? And it is on this note I will actually want to call out one of the countries because obviously we implemented this in Benin because this it was politically driven. The president was like, hey, I need to have more information out of the households, and NMCP, as you are planning to do this, you know, I want you guys to help us to collect this information, and let's see how we can use this to plan and triangulate with the census data that we already had. So it was easy to agree to receive all this information. Please allow me to spend 2 or 3 minutes to even explain to you the details within this data. So from 1 to 5, is this still working? Okay, sorry. Okay, so from 1 to 6 is the administrative information. Then from 7 is the geo coordinate. 8 is the name and the surname of the head of household. 9 is the nationality. 10 is the phone number of the head of the household. Now, please note that we are receiving this, the nationality of the head of household, differently. So, the fact that we receive this information does not mean that the whole household is of the same nationality. I hope you are getting my point. Now, then let's keep going. Then you now have the total number of persons living in the household. Then you also have the total number of people who frequently sleep in the household. So, this means that the INSAE team, the statistic team was like, hey, if we have these two data, on our part, we can now use it to kind of calculate the false index in the data and the people who would actually be moving from household to household, who sleep across different households, so that we can, you know, obviously we can just have an expectation of the roving population in the population set of the country. Now, thinking that that was enough, and then we kept going. So for each member in the household, all these questions would need to be answered. Now, this is the interesting part. Now, if at this point we are saying that, okay, we have like 6 people who sleep in the household frequently, so you now have to receive the name and the surname of all the 6 people. Then, you know, obviously you now have to get like the sex information. Then you now have to get, how is it related? Okay, then you now have to get the relationship between this person and the head of household. And this set of documents that were received. If it's the wife, if it's the child, if it's the grandchild, if it's the niece, if it's the father, sister, son-in-law, the house help, or if this person is even in another household, but obviously just came to this household as at the point of enumeration and was added to the database. Now, interestingly, okay, then you still, what's going on? Okay, so interestingly, you still don't have an information if this person sleeps in the household, and then if this person had slept in the household last night. All right, and then you receive the date of birth of the person, the nationality of that person, and if the person is a female, then you also ask if the person is pregnant or not. I thought we were done, but no, we still would go ahead to ask the due date of that pregnancy. You can imagine how this enumeration process was collected. Now, this was a rigorous, difficult fight. At some point, I would go to the office of the president because we had like, it was under the CCM, and the CCM was under the presidency at that time. And just to advocate, to say, you know, if we would be able to kind of just reduce a few of these data sets. But his statistic team were very clear to say, no, we need this data because we need to do a whole lot of analysis with this data. Thankfully, we did that because there is a lot of learning that we are still trying to harvest out of this data since the past 3 years. Now, let's keep going. That was the case of Benin, right? Now, let's look at the trajectory across 1, 2, 3, 4, 5 campaigns. Typically, what are data sets you receive in an ITN campaign? Right, you receive the administrative unit, the name of the head of household or the caregiver, the phone number of the head of household, the number of people living in the household, and those who sleep regularly in some context, the geo-coordinate, and a unique identification. These are the basic set of information you need for an ITN campaign. So that means if I want to do an ITN campaign now, if I have that data set, I'm good to go. Do we agree? Do we agree? Anything missing there? Nothing. Good. Now, let's look at SMC. SMC If I have the administrative units, if I have the name of the head of household and caregiver, if I have the phone number, the name and the age of the child, I can implement an SMC campaign. Do we agree? Now, if you look at the SMC, all right, data set and the ITN data set, 4 and 4 could be the same thing and could be different. Now, so if in the case of the ITN campaign, if I receive the name and the age of everybody in the household, this means that I have also received the same information that I can utilize to do an ITN campaign, SMC campaign. So this means that I can easily reuse the ITN campaign to implement my SMC campaign by just changing what? By changing number 4. So instead of establishing a household registry, all right, what am I going to be establishing? Individual registry within the household. Does this make sense? So now you can see that just with this simple change of number 4 here and number 4 here, this data can be reusable for SMC campaigns. Does this make sense? Good. So now, let's look at SMC and UNCO campaigns, right? Now, UNCORAS's campaign, you still would get, you know, the administrative unit, the name of the head of household, and so on and so forth. Why does it keep going off? Is it us? Okay, okay, yeah. So now you would see that UNCORAS's campaign as well would require the age of everybody living in the household. And the reason is because you don't give the drug to children that are under 5s. So if you don't receive the age of everyone in the household, you will not be able to identify that group and exempt them. So while SMC could be given to children under 5, UNCORAS is given to children you know, everyone in the household that is above 5 years old. So now you see that if we only change how 4 is collected, we can use it for both ITN, SMC, and UNCORAS's campaign. Does this make sense? Are we following? Okay, so let's look at vaccination campaigns and vitamin A, you know, supplement campaigns as well. So you see that the same information you receive in SMC and you receive in UNCORAS's campaign is the same information you require for a vaccination program. Nothing different. If you have the name of the household, citation of the household, and the age of everyone in the household, you should be good to go. Now, let's look at a nutrition program. And nutrition is on, you know, like food distribution, etc. The only 2 elements here that seem to be different are the weight of the child and the mark information of the child. I hope we know that thing they put on the arm to measure, you know, that if the child is malnourished and so on. So now you see that if we have an ITN registry where we change 4 to receive the name and the age of everyone in the household, we can easily reuse that through all the health campaigns in malaria, ITN and SMC, all right? Outside of malaria, we can use it in NTDs, all right? Outside of NTDs, we can use it in vaccination. Outside of health, we can use it in what? In nutrition program. Does this make sense? So now, the question is, if I use this data, for example, ITN campaign data, and this data does not have the 7 and the 8 that I need for an UNCO campaign, how do I then establish and add this additional information to ensure that I can use this for other campaigns. I think these are the things that the framework would be establishing for us. So, in view of this, I think we can take a pause now and let's do a quick group walk. Is it moving? Sorry. Yeah, just change it from here. Just a minute, sorry. Okay. So I think, having listened to me for the past 15 or 20 minutes, I think we should just do a quick group walk at each table. So in the context of what I've just explained, can we just use 10 minutes and agree on each of the table the list of data sets that you think should be received or collected in a specific health campaign? In case you think differently, all right, so can we just do that quickly? So you can just, one of the sheets here, and let's agree on what we think should be the base information that each ITN campaign should be receiving that will aid the reuse of this data. So can we just do that quickly in 5 or 10 minutes? Thank you very much. The time starts now. 5 more minutes. Thank you. One more minute. A minute key rest. Okay. Okay. Merci beaucoup à tout le monde. Thank you, everybody. So I think we are going to start by listening to... Who wants to go first? Which table wants to go first? Should we start here? Should we start here? On peut commencer par ici? Okay, bon. On peut commencer par ici. Yes. Okay, I think we can start here. Please, Paul. Thank you.
Okay. So for us here, we have... hello, everyone. So for us here, we have the administrative data, the name of the head of the household, the phone number of the head of the household, the number of dependents and their gender, number of people regularly sleeping in the household, the number of children under 5, name and ages of dependents, the geocoordinate unique ID, then the number of pregnant women, height and weight of dependents, and middle upper arm circumference as a consolidated data for across all.
Okay, thank you very much. So let me keep this document. So let's ask. What did you say? Okay, so his list is administrative data, head of household information, phone number of head of household, number of dependents, their gender, number of people who sleep in the household frequently, number of children under 5, name and ages of dependents, geo coordinates, the unique ID of the household, number of pregnant women, I think, height and weight of dependent, mid and upper arm circumference information. Okay, interesting list. So can we start here? Okay.
One thing we mentioned is we thought it was very good, the list. Hello? Okay. For administrative unit, to be able to capture like what's the community that household belongs to and the cascade all the way up, community, the catchment area for the health facility, that's a benefit. We had a side conversation that wasn't involving everybody, that maybe for height and weight, you don't capture those. You just take a sample, and because it's just used for quantification of the medicine, so you don't need to ask that for every single person every single time, maybe. We had some discussion about, do we keep the name or in the phone number, or can you remove that one? I think we decided to keep it because of the need to be able to do longitudinal tracking of the medicine. Did I get that right? Yeah, okay. Anything I'm missing? Okay, thank you.
Thank you very much. Can I have your list? Or could you just complete it and give it to me? Thank you. All right, so let's take this table.
Okay, we said that we will retain the administrative unit. We'll also have the name of the household head. We have the age of the children if they are there in the household. Then we also get the phone number of the household. The number, of course, we love the number of children under 5 in the household, then get the age. Then we'll also want to know whether the children under 5 years have been vaccinated. We also get the weight of the children and also measure the mark.
Okay, thank you very much. I hope I can keep this. Thank you. So let's take one more on the Francophone side. And okay.
Merci beaucoup. Alors, nous avons retenu comme information les informations administratives, le nom du chef du ménage et des dépendants, le numéro de téléphone du ménage, le nombre de personnes dormant régulièrement dans la maison, les coordonnées géographiques, l'identifiant unique du ménage et enfant, et le nom et l'âge de chaque membre de ménage. Bon, ceci inclut les petits-enfants, donc du coup, ça pourra être utilisé dans ce sens-là.
Exactement. Merci beaucoup. Donc, on peut juste faire le résumé. Les premières... I'm sorry. Okay, so I think I'll just give a summary of what they said. First is the administrative information, name of the head of the household and the dependents, the phone number, the unique ID number and phone number of the household, the number of people who sleep in the house frequently, the geo coordinate of the household, and the unique identification of the household and the children in the household, and the name and age of every member of the household. All right, so in summary, can I have your attention, please? In summary, okay. Okay. Somebody wants to speak? Okay, maybe it's from the other room. Okay, that's fine. Yeah. So, in summary, I see us agreeing to, which is what we want to try and establish in the context of the framework, is, please can we have your attention? It appears that the information on this line is what everybody is requesting for. Now, we have 3 exceptions. First, we have some people who think we should receive the weight and the MUAC reading. 2 people agreed that we should receive the weight and the MUAC reading, and 1 person is saying we should add the height. Okay, excellent. Excellent. And I think another person is saying we shouldn't include the height, weight, and pregnancy status, which we think this framework is tending to this. And this is based on the lessons learned on the ease of collecting the data and the context of necessity and the level of effort, all right, that is required to receive this data. So let us just take an example. If I want to just give an ITN campaign, and we go from house to house, you know, measuring the height, the weight, and the MOAC reading, I'm sure that by the time that campaign strategy gets to Almasi to review, she's going to turn it back to she's going to turn it back to us. All right, so yeah. Okay, no. Okay, excellent. Agreed. So we have one down. So that means the argument we have is true. And that means this framework, no, please can we get the screen back? Sorry. We're so sorry, we don't know why we are having too many technical issues, but so we are back. So now, so why do we think this will work? I want to end this conversation now before I move to the next presenter. We think this could work because guess what? If we have the registry being established where we have the name of the head of household and the children being listed out with their ages, we should be able to have a unique trace to add every other information that builds the trust of data. Now, if we are going to come back to what we said, in the context of building the application now, we are going to put some unique metadata that will help us to link it across campaigns. All right? So that means that you will know that, oh, this same person is actually the same person we met in a mailed campaign or in an SMC campaign. And then you can just add that information and you have the reference information to link this data. So now, I think we should move to a few of the real-life cases that we had from Ghana and Benin. I pray that Dr. Rock gets here. And then after that, we'll just move straight into the framework and understand like how the framework works. And then we'll do a quick exercise in our country context on how to use the framework as we go back. And let's see if we can begin to get like early results from this. So I'm going to leave the floor now to my colleague from Ghana.
Okay, so I'll be talking about how we reused SMC household data for PMD LLI registration in Ghana. Now, the reuse of data, we've done that in two different ways. So the first one was the SMC data. Now, in 2023, after we were done with or we were about to start the SMC campaign, we wanted data from previous years, but realized that they were all siloed in different databases. So to eliminate that, what we planned during that year was to use after we are done with the registration for the households and the children, in the following year, 2024, we'll reuse that same data. So children who were registered in 2023, and then who were still within the age gap, we graduated them to the following year, which is 2024. So that was the first reuse. Now in the second reuse, I think. Okay, so now the second reuse was during PMD, point mass distribution. Now we wanted to do PMD and then SMC at the same time last year. But then the challenge was that in previous campaigns that were held at the same time, SMC data was collected and then PMD data was collected differently. So in order to eliminate that, since we already had data from SMC, household data from SMC in the SMC regions, we had the household name, the administrative data, the first name, last name, the ID number, and all of that. What we decided to do was to reuse the SMC data of the SMC household data from 2023 in 2024. So the household data was already in the system, and then during the registration, all they did was to recall that data back to the tablets and then update it, since we didn't have the number of people in the household, but then we had only the number of children in that particular household. So they recalled the data, it came offline, then they updated it. When they were done, then they synchronized it. So during the update, they put in the number of people in the household, and then it generates the number of ITNs that are supposed to be given to them. Okay, so reusing this SMC data, it was very efficient. So the households were not re-registered again. So the cost effectiveness, so it reduced the number of field logistics that were needed. So if the two campaigns were to be held differently at the same time, it would have increased the number of personnel. Maybe the registration assistants and the volunteers would have increased, and it would have increased the number of the days also. So if we were supposed to do the two of them at different times in the same year, probably would have done SMC for 7 days and then PMD for another 7 or 5 days. But then because it was combined, we were doing the entire campaign for 7 days. So now, before the campaign started, we made sure we validated the data, the SMC data, before we proceeded to do the PMD. Okay, so how it worked, I think I've done a little explanation, but I'll go through it again. So data was retrieved from the SMC 2023. So what happens is that we have one system which has all the interventions on it. So we have PMD, we have SMC, we have school distribution, and then larvicidin. So it's the Ghana Malaria Intervention System. So in using that system, it has the household data for SMC. So since we are using the same system for the PMD also, what it does is that you pull the data from the SMC household registry, it comes to the tablet, and then you update it. So the volunteers had access to the households on the GMIS app, and then they marked whether the households wanted LLIN or not. Okay. So this updated records guided the net allocation and then the delivery. So what it caused was it reduced the time for registration. Since we leveraged on existing SMC reach, the coverages were higher, and then there were fewer errors due to pre-validated records. And it also saved costs on the use of field volunteers. Now, key challenges, missing households. So there were some households that they enter, and then probably they made mistakes in the writing down the unique code. So when they search on it, when they search for the codes, they can't find it. So what we did in such instances was that they had to send the details that they were searching for to their district or sub-district supervisors. So they also had access to the master list. So and then they send them the correct one, and then they're able to update the records. Some volunteer also required training. Although we had done trainings for them, some of them still required refresher trainings and on-the-job coaching. Because they were used to doing the two systems separately, some of them, they forgot how it worked, and then we had to coach them again on the field. So the key takeaways. So in order for this to work, we made sure that the SMC and then the LLIN teams coordinated early. So during the micro plan stages and all, we made sure everyone was on the same page to make it easier. Now, on the data cleaning matters. So we invested time in validating the existing data before we reused. And then last but not least, we sensitized the households beforehand to improve uptake. So some of the households, they were probably expecting that we register them again and then give them new codes and all of that. But then we sensitized them that since they were already part of the SMC, there was no need for them to be re-registered. And then the good thing about the SMC was that during the registration of the SMC, there are some codes that are generated for the household. So for most of them, because their children have maternal health and record books, which they take to the hospitals every time, those codes were written in it. So the chance of it getting missing was quite minimal. So recommendations for future campaigns, we recommend that we apply this model to other interventions, and also we are pushing for interprogram collaboration. So aligning SMC with the SMC and the LLI with immunization data systems like the MDA, the vitamin, and all of that. Okay. So in conclusion, doing this reuse of data, it saved us time. It also proves that integrated health data systems improve efficiency. And then the way forward is that we'll scale up the data reuse strategies in Ghana's malaria programs. Thank you very much.
Thank you very much. I think we should please save our questions till the end of this because our time is almost out, and I don't think we have reached on the framework yet. So I think we would go to the next presentation.
So good afternoon. I'm going to present the opportunities for data reuse through establishment of data registry. I'm from IGAF, so I'm going to basically tell the journey of DIGIT for data reuse. So has everyone agreed that it's very important to use the data? I'm going to skip a couple of slides, so can you go? The first slide about data registries is a new concept, so I'm going to just spend 1 minute here explaining what we believe that is data registry. Data registry, first of all, is when you collect the data, everyone is collecting the data, but the second and most important is keeping up to date that data. So that is what makes the registry, make it a single source of truth. So having these registries is what we aim using HCM. Some couple of examples of registries in the environment of health. So some registries can be health facility registries. So meaning having all the health facilities that you can keep updating all the data regarding those health facilities. Beneficiaries, also boundaries, administrative units in that case, households, as was indicated in the previous slides, health workers, the people that are working in campaigns, also they can have a registry that can be reused for several times, infrastructure and also settlement. Those are a couple of examples of registries that we can keep. And quickly, I think everyone is aware of the importance of the reuse of data. Can improve resource planning, accuracy, also have impact on the cost. I think everyone agreed for the survey. But going to our journey, how do we enable data reuse? First, I'm going to talk about HCM, that the core of HCM is shared data. Can I have this? Okay. Shared data registries. This is the core, meaning that is enabled to create those registries that can allow to collect and also keep those data updated. That can happen through the usage of HCM, also through APIs that allow data exchange, so mean that other application can come and also update those data or even insert new data so that you can have a single source of truth sitting there. Also, it was also highlighted that it can be used beyond health. Also, meaning that you can also include others domains here outside of health that can use the same shared data registries. In this example, in the health domain, you can even put several types of campaigns using the same shared registries. So this is on the platform side, and on the data collector side, we also have a couple of features that are important in case of the usage of data. The first feature is as my colleague also indicated, you need to download the data in your phone. So to allow to update those data. The second is ability to find what you're looking for so that you can. So to find it, we have generate beneficiary ID, automatic generation beneficiary ID that allow to basically while you register a beneficiary, it generates ID that you can use to track that beneficiary, and also you can link that beneficiary to a unique watch that you can read using QR code to update that beneficiary. Also, to enhance the search, also you can also make search based on geolocation. So, mean that I'm going to search for people that are 5 radius from where I am, so that it just limited the domain of search. You can go. So I wanted just to get here. I think this is the most important part. This is basically what our learnings on data reuse. We have implemented ACM in a couple of countries, and what we have been, what we have saw until now on data reuse, on beneficiary use, for the same implementation, the same geography, we just saw that there is a less than 25%, meaning that even when you have data available there, the reuse can be less. And for that, we have a couple of recommendations that can be implemented. I think this also linked to what was said in the beginning, that it's not only technology, it's people and process that is more that more impact on data reuse. And for that, first is improvement of training, because the field worker need to understand how to search, to find the right household, to update that, because if he doesn't search it, he will going to get duplicates, and he will end up having $6 million households where you only have 3 million because of duplication that happened. And the second part is kind of policy, looking to behavior change. If we incentivize the registry usage, mean that you are going to track who are using the data, so that you can incentivize maybe monitoring, or even for future recruitment, having them as a priority. And the reuse of data depends if you are able to search them. And although we have search by proximity and other option, if you have a beneficiary ID, that make it more easy to find the households and the beneficiary, and also update those data. So the less recommendations to implement this unique identification of beneficiaries, so that we can reuse those data. I think everyone is aware of the benefits, so I'm not going to touch here. The second registry that we want to also talk is administrative hierarchy. For here, the situation is very different. For the campaign that we end up reusing the registry, it was 100%, meaning that for the previous campaign they used the same administrative units, so that is very good. And this also is driven by the policy. It's necessary to have that policy that we are going to use, because some of the times the programs try to change the boundary, so it's necessary to have a policy on that. And our recommendation here is to adopt a standard boundary across all campaigns types. So I think, I think we jump it. Okay. So we also have one of the research we also want to talk is the user registry, the people that end up having credentials to use the system. So you can reuse it, because are the same national supervisors that end up working on several campaigns, the same supervisors that work in different types of campaigns. So this data also can be reused. And what we have seen until now is that the reuse is only on the supervisors, that is less than 10% of the people involved within the campaign. the field workers, their data is not reused, so they're not track it. And one point that I want to highlight here, if we track those field workers, we can do kind of analysis, maybe try to compare the performance between campaigns. Someone performed badly in one campaign may not go to another campaign. So these are things that you can do when we use data from user registry. Recommendation first is to, most of the time they come and just have credentials, so we don't do onboarding when we make registration and capture more data of those users. So if you do onboarding and capture more data and give them not code users, but the named users that they use through campaigns, that is something that also we recommend. And then the reusers also to have the same line workers being used for different things. That's also something that also we recommend for user registries. So this basically was wanted to talk about what is a registry, how HCM is enabling registry platform, and what we have seen until now, looking to the separate campaigns that we have been supporting. So thank you.
Thank you very much. Please put your hands together for Harvey. I think on that note, we will go very, very quickly into the framework now. Let's see what we are proposing on the CRS side. Okay. All right. Okay. So first and foremost, let's look. I'm so sorry. I would need to run very fast. Okay. So first, what are the opportunities of data reuse? He had called out two different aspects that I don't think we are looking at, right? So, you know, in the context of campaigns, we are more conversant with using the, you know, information that we get in the household, you know, the name of people and so on. We still have more information, right? Information around like the user registries, the warehouse that were assessed in a particular campaign. I've realized that we don't even reuse the warehouse data. And we have this information, right? You know, context of the location, the spaces and so on, but we don't use that data, but we have it. So here, we are saying that you can, after you have done the first campaign on digitalization, you can use that campaign as your micro planning by just doing two things. The first is what? Extrapolating that data with your annual growth rate. So let's say in the case of Liberia now, we have done the campaign as at last year, right? You can just take that enumeration data, extrapolate it, all right, in the context of adding the growth rate, and you can obviously just come up with coefficient on the inflated data set. So this means that we can look at the data and obviously just run a few, what's it called now? Statistical models, and we should be able to, you know, understand if we have some false coefficient in the data that could be used in this estimation. So this means that you can take that data, all right, extrapolate it and utilize it as your macro planning data or your micro planning data. Will this work? Yes. We have done it so far in 3 countries and we saw a less than 10% difference in the reuse of that data. 2, you know, in the case where you are receiving the same data, so let's say that you have done an ITN campaign and you are receiving another data, additional, let's say SMC or ITN and so on, you can receive new data on the existing data if this is already planned in your registry. If the kind of system you have allows you to contribute to your registry. So in the context of what we have across like ministries of health and so on, we only just have like point solutions where if you want to add another data set, all you need is about just adding another table in the data table. And with that, you cannot reuse it, except if this is a registry. And then, it can now be linked with, like information around like the unique identification and the metadata. So this is why we are recommending to do this with a system that avails you the opportunity to establish, all of the registries that could be reusable. Now, I've spoken about the storage locations, and I think I'm going to move to this slide. I'll spend just a few seconds here on the limitations to the reuse of data. I think we already know those, data quality issues, inflation, and so on and so forth, and lack of interoperability between the tool you are using and the tool that will be used with other systems. So, in the context of CRS, I think our framework is looking at, if you have a data registry, regardless of the tool you use in the different campaigns, this tool should actually be able to reuse the data you send to them and contribute back to the repository as a standard. So, let's keep going. On the framework, we are establishing 4 key steps or components. Now, the first component is conceptualization. In the Ministry of Health, or as NMCP leads, if you think that this idea is useful and important, and you would want to kind of drive this, it is important that you think through how to conceptualize it. And, in the context of the conceptualization, we have listed out, I think we have about 11 things that you should do as recommendations that could help you establish a concept on the reuse of your ITN campaign data. So first, we said that you should establish a concept note that is very clear on your intentions to receive a data that should be reused. And in this context, in the concept note, it's also good to be clear on the specific, the campaign types that you would want to reuse this data. So in the previous example, if you want to do ITN and SMC and so on and so forth, list out all these possible campaigns. And the reason why you have to do that is because you need to sell the idea to the different units who are responsible to lead these campaigns. So that means if an ITN campaign manager, for example, if Alade is planning to reuse it for SMC and vaccination and so on, he is expected to have his concept together and go and exchange with the different unit leaders and say, hey, this is an opportunity, we think this is going to help you. So if all of this is clear in your conceptualization phase, it is easier to have a sense of direction on how to go with this. 4 now, is to have a clear list of the baseline data that you would want to receive. So now, if in the exchange that you are having with the SMC lead, and it's like, oh, we have received this request to also maybe just collect, the list of children who have missed like their vaccination information. Could we add this information? Now, because you have had the opportunity to go ahead and exchange with the SMC person, you would also know other issues and commitments that they also have with other programs, the context of integration, and you can already incorporate all of those feedbacks as you are trying to establish the baseline of the data set that you'll be receiving. Now, on the same table here, in the instruction, you realize that we had established to be like, okay, in an ITN campaign, should we receive this information, this information, this information? But you realize that, in the context of reading it, they still did not also get it. So now, this is why it is good to be very clear and have these exchanges and establish the clear concept on the use cases of the data and the kind of data that has to be received. Now, if that baseline is established, we have the big elephant in the room, which is the administrative unit has to be reconciled. So what do we mean? In some countries, in the same program, malaria program, SMC, we have a different list of villages. ITN, we have a different list of villages. As long as these administrative units don't align, there is no way you can reuse that data. And to the point of Harvey, right, as part of the registries that you would be establishing with any form of repository, or if it is a DPI, you would have the opportunity to establish the registries on the administrative units as a baseline that could now be reused through different systems. So if I take a case of Liberia now, if we want to reuse that data, and let's say we want to use a different tool, if it is like a Kobo Collect to do a vaccination campaign, because the Ministry of Health has agreed that we are using the same list of administrative units, we can immediately just take the data from here and push it to Kobo Collect and add any other information that is needed. So that means interoperability now becomes very easy, because this phase of conceptualization has addressed a lot of these issues. Now, I'm going to give the case of a country. We looked at the SMC and ITN data, and guess what? 26% of the villages do not align. The same program, 26%. If less than 10%, of course we will understand, all right? You know, but 26%. So now you would see how much work we have to go into this in the context of standardizing this. Another recommendation is you may struggle in the context of standardizing it within a specific program. SMC will say, no, 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 no. This is what all of our field workers understand. These are the villages they know, like we cannot change it now. We cannot do this. We cannot do that. So we are recommending in the framework that you might need to engage with the Ministry of Statistics, regional or urban planning. It depends on what is functional in your country, to get the necessary information that could help you to justify. Now, in the case of this specific country, it was difficult to align these two units in the same program in the Ministry of Health, SMC and ITN. So we had to go to the Ministry of Institute of Statistics and National Planning, and they said, no, we have a law, and this is what the law said. These are the list of villages. Any other list of villages is not recognized. So you guys should return back to your program and realign. And with that, we had a justification to realign all the villages. And guess what? The minister, he was able to just give a decree in writing. All of us that are used to like French countries, all of those memos will come out as a decree. And he kind of decreed that, we should use this list of villages through all health programs. And the adoption was very, very simple and easy. Now, in the framework as well, we are saying that all stakeholders who will be generating the data and reusing the data, so that means if you have an intention to use the data, please bring them into the conceptualization phase. So that it's not when you've gone ahead and collect the data, it's at that point that you are now, engaging with them. Now, in the context of doing that, key staff should be identified. It's not about just saying, oh, you know what, I have informed them and they are aware that we are doing this. No, key staff should be identified and included in the routine engagements and meetings on this data reuse. If not, it will be difficult to gain a lot of traction. Now, this is where we have the most problem. Where should the data be stored and who should be responsible? Point of conceptualization, it has to be very clear. So this is why we had to ask that question in the Menti to say, who do you think should be responsible in the context of managing the data. Now we have a twist to it, which I'll be explaining in the next slide. So let's see. Ownership and the access control should also be clear at the point of conceptualization. Who should own? Who should give the access to this data? Let me just explain our context of ownership. Now, Nkoriasi's campaign would be the team that would be adding the height on the database. Let's say you use an ITN campaign. So to them, they would want to own any other changes of height in that database, even if another program has something that is related to height. And we had, in the case of this specific country, okay, we had seen the issue where SMC had received the list of children under 5, but guess what? In the context of the polio campaign, we had this huge argument to say, hey, you cannot go ahead and, add children and scatter everything that we have already done and cooked up. We had this argument to the point that they refused, the polio team refused to use the data set because to them, they think if we add that data, we would want the malaria team to change it in the course of their campaigns. But guess what? This framework is able to give us a way around that in subsequent campaigns. I think I should even just explain it. So now, if you have tools that have like registries, you can save the data of a specific campaign. You can just leave their contribution on their own registry. However, it is speaking to the baseline registry that has the previous information dated in time. So that means if you don't want to also use like the contribution of another team, if the data is not clean and so on and so forth, you can return back in time and reuse what you are most comfortable with. That's because you have built a lot of trust around that. Now, provision should be made for the reuse of the data at the end of the review of the data at the end of each campaign. Now, who should be doing the review? Everybody that has an intention to reuse that data. And the reason is because if they have issues of mistrust of the data, if they have things around the data that they obviously don't understand, it is good to give them the time to clarify this and answer their questions and also just walk through that with them. Then the last point is at the point of conceptualization, you should be able to list out the statistical models which you would use to clean the data or check the data quality at the end of each campaign. Examples of this statistical model, I would be doing that in the next few slides. Now, as part of the first step is also on advocacy, because as you are building the concept, it's good to also be advocating to all of the respective persons within the Ministry of Health who you require to establish, all of the data sets as needed. Now, on step 2 of the framework is about establishing the governance and the policy framework that should guide the collection of the data, the access of the data, the use of the data, the updating of the database, and so on and so forth. Now, we have had 2 key areas we've faced a lot of challenges around, like the governance of this, and we are happy to elaborate that, in this framework. So, the first is the fact that the malaria team is the one that is leading the generation of the data and advocating the reuse of the data does not mean they should keep and manage that data, the database and so on. So we've seen a significant problem where the fact that this whole data, like the of the reuse and so on, is with the NMCP team, other programs don't want to use it reluctantly. So it is best to institute a committee that is higher placed than the NMCP and other programs who could decide guide on the use of the data and the management of the data as well. Now, please note, in this decision, you must ensure that the right subject matter experts are the ones leading this committee or playing a key role in this committee. In one of the countries, and part of the recommendations that we gave, it was the head of vector control who was the lead of the data management committee. And that brought a lot of challenges because of how the database should be, the structure, and so he is looking at it through, obviously in the lens of vector control management. But the technical team had other recommendations, and it was difficult to navigate through that. So it's always good to have like the subject matter experts to lead these conversations as needed. Now, two key work streams that have to be established is this. One, as we already had agreed, that this data should be managed by the HMIS team or the M&E team. However, we have a difference between the storage of the data and the management of the storage of the data and the management of the data itself. So what do we mean? In IT, the fact that you know how to play around with Excel, SQL, and database and so on does not mean you would have the skill set to host a cloud infrastructure that can manage a repository. So we always would mix these two things up. It has to be very clear. A data repository has to be managed by, in most cases, experts who have experience in infrastructure management, like database management and cloud hosting and so on. So the fact that the HMIS team are good with Excel and DHIS too and so on doesn't necessarily mean they would be able. So we have had this confusion, and this is why we are trying to put this in the framework to ensure that the roles and responsibilities are clearly detailed and all of these work streams are established. So that means if it comes to things like hosting and all, oh no, I'm 1 minute on my time, and I think we still have more to go. So let me keep running. So this is still on the governance. I think I will, okay, let me just say one more thing on the governance. Now, in the context of introducing the governance, we've learned one key lesson, that for this to be successful, whoever needs to lead that governance committee has to be an influential person. So this means that in the context of adapting this framework, in your country context, you should try to look at these things. If not, you would face a lot of challenges with this adoption. So let me just give you this quick example. Please follow me. Now, this is the signature of the person who led the committee in a specific country. Please watch me very carefully. These are the person's roles. Only one person, all right? He was the coordinator of all the external funding in the country. USAID, Global Fund, all the external funding, he was leading that discussion as the coordinator. This same person was also the coordinator of the Global Fund CCM within the country. Now, this same person, he was situated in the office of the presidency, dotted line supervision to the Ministry of Health because of the resources and all the finances that he was getting. And also, his experience in sociology and, and health policy management. So, a lot of the ideas were very, very easy for him to sell this through the different units because, you know, he was heavily respected and he was a heavyweight in the room. So it was very seamless to do this. I wish that the Benin team was here. We reused this data for 3.5 years and for 6 campaigns. 3.5 years and for 6 campaigns. Imagine the cost you save in not doing an enumeration for SMC campaign for 3 years. 2020, no enumeration. 2021, no enumeration. 2022, no enumeration. And guess what? Nobody complained. Nobody. If you know what if you know what it means to cut all of the per diems and so on, and nobody traveling, no trainings, for enumeration, nobody complained. So if you don't have this thinking in the setup of your framework, it will be difficult to move this, to kind of move this to success. Now, on step 3, we have the infrastructure, the implementation, and the kickoff. So first, these are key recommendations we have to the different countries that are sitting here, is as you speak with, like different tech vendors and so on, set your standards of interoperability. So that means if you are bringing a new tool, all tools could be accepted, right, and piloted. But guess what? If those tools meet the standard that allows you to link information between them, you will not even know you are using different tools within your campaigns. You will not even know, because all of their data can obviously be synced and saved to a specific repository and reused and brought back and reused and brought back. And the database just keeps growing and growing and growing and growing. So now, if you don't have these standards, it's difficult to help the different programs to align as needed. 2, you need to have a clear data dictionary. What does a household mean in an ITN campaign? Does it mean the same thing in an SMC campaign? Does it mean the same thing in a polio campaign? If I say a unique identification, but does this mean the same thing through all the different programs? So it is very much important that we do this through all the different programs. Thank you, Robert. I think I would stop in the next few slides. So please, if you have the time, please read on the FIRE standards and understand what the standards are. And then the last point on the framework is on the capacity building and training. So if you have this framework being established and you have the tools in place, you have the repositories in place, if there is no consistent training of the respective people who will use the data to know how to use the data, it will be difficult to have them to use it. And the last point is on the monitoring and the evaluation of reuse. So the fact that we use that data from ITN to do an SMC campaign, did we check? Did it add value? Is it kind of because it was a powerful person that kind of just co-opted all of us to use it? Is that why we used it? We need to do these reviews using a clear model that helps us to monitor the progress of how things go. Fortunately, I have to stop at this point. And then these are the last recommendations for data use. Is 1, make it easy. 2, make it simple. 3, make it friendly. These are the core principles that we are advising in this framework. Make it easy, make it simple, make it friendly. Thank you all for listening. So I don't think we have opportunity to take questions because our times are up. But please, you can just ask questions to the final list of questions that we hope to get from this workshop. All right. Thank you, everyone. I think we need to move back to the bigger hall. Thank you.